The last time we talked about all the solid components of blood, so that'd be the erythrocytes, leukocytes, and the thrombocytes. Today we're going to finish up with the components of blood, looking at blood plasma. And as we saw at the beginning of the chapter, when you saw the picture of blood centrifuged out and all the red cells fell to the bottom, what percentage of blood do the red cells take up? About 45%. Okay. Um, if someone, and what is the medical term for the percent of blood cells, of red blood cells in whole blood? The the what? The packed cell volume or hematocrit. Hematocrit. You hear about that a lot. If somebody, if they're in the hospital and they're having a lot of issues, and one of the tests they run is a hematocrit, if the hematocrit is dropping like below 20, that means it's time for a blood transfusion. So they look at that a lot. Um, but anyway, today we're going to look at the blood plasma, and it is clear. And of course, that's the liquid part of blood. So it makes up the other 55%. And you know that you might wonder, well, where do the leukocytes and the thrombocytes occur? And that's less than 1%. So we talked about all that before, right? Okay, now of all the components in the blood plasma, it's mostly water, of course, and then a lot of dissolved substances. So you can see a variety of these dissolved substances. There's gases, there's nutrients, there's hormones, vitamins, all kinds of things dissolved in the blood plasma. Um, but of all those things dissolved, the biggest component is a protein component. So we're going to analyze some of these various components and um, look at their benefit to us. We're going to start with the plasma proteins because those are the most abundant. And let's see, do I have them? Look right here. You need to know these as if I typed them up in the notes. The different kinds of plasma proteins are albumins, globulins, and fibrinogens. Albumins, globulins, and fibrinogens. And of the globulins, there's three different categories, which we'll look at. Okay, do you notice that the percentages here? Do you notice that of all the plasma proteins, the albumins are the most abundant? Do you see that? Okay, that is extremely significant. Extremely significant. Of everything dissolved in your blood plasma, now I'm not talking about the cells, I'm talking about the dissolved substances in blood plasma. The one kind of molecule that is, or substance that's most abundant are the albumins. And because of that, they give it the function of maintaining the blood's osmotic pressure. Now, we talked about osmosis in A&P1, and I told you that you will see it in action in A&P2, and we'll see it in a lot of chapters in A&P2. So what I'd like to do is go through a quick little review of osmosis so you'll understand in future chapters, especially when we start talking about this thing called osmotic pressure, what that is. Okay, and so that's what this next slide is. I'm just going to do it. I'll put a picture up and I'll just go through it. But when you get home, here's a review for osmosis for you. Okay, and then you've got some pictures that go in. So all of that is a review of osmosis. Okay, those two slides. Okay, but I think what I'd rather do, instead of just reading through this, I always like to do osmosis on a blank slide. So some of you have seen this before. I apologize, but that's what we're going to do. So, all right, let's imagine that you have a beaker and it's divided into two halves, separated by this semi-permeable membrane that has tiny little microscopic holes in it. Okay, so if a particle is smaller than the holes, it'll pass through. So it would be permeable to that particle like water. And if something's bigger than the hole, it won't pass through. So it's impermeable to that particle. And I'm going to put two solutions on here, one on each side. And let's say they're sugar solutions. And over here is 10% sugar. And then on this side is 20% 10% sugar. And so when we talk about solutions, remember you have a solute and a solvent. Okay. What is the sugar in this example? The solute or the solvent? Solute. What's being dissolved is a solute. And what it's dissolved in is the solvent. And for this class, the solvent is always water. Okay? So a sugar solution on side A, we have 10% sugar, 90% water. On side B, we have 20% sugar and then what percent of water? 80. Okay. And this membrane is not permeable to sugar. Okay? But water can cross it. And you've got, because it's small enough to get through the holes. Okay, so you've got water randomly moving in both directions. What is the net movement of water going to be? Go back to AMP1. From A to B or B to A? It'll be from A to B because A is 90% water, B is 80% water, right? And it goes from high to low concentration. Okay, and then over time, this level is going to rise and this level will drop, but it'll even them out so they're both like 15% sugar, 15% solute, because one side's gaining water, so it's becoming more diluted. The other side's losing water, therefore it's becoming more concentrated. Okay, prior to the movement, I want to use a word called osmotic pressure. Okay, in AMP1 we use words like hypertonic and hypotonic. Okay, so prior to the movement, is side A hyper or hypotonic to side B? Y'all forgot that, didn't you? Side A is hypotonic to side B because the hypo and the hyper are not referring to the water. They're referring to the stuff being dissolved. They're referring to the solute. So side A is hypotonic to side B. So do you see how the water moves toward the area that's more hypertonic? Side B is hypertonic to side A. Okay? Prior to the movement, we say that side B has a higher osmotic pressure than side A does. This has a high osmotic pressure. Side A has a lower osmotic pressure. Osmotic pressure, in my mind, this is not a textbook definition. This is my definition, and it makes me always get the questions right. Osmotic pressure is due to the presence of the solutes. The more solutes, the higher the osmotic pressure is. Okay? Osmotic pressure allows an area to retain water, to keep its fluid. As long as there's a lot of solutes there, it's not going to lose too much fluid. Does that make sense? As long as there's 20% sugar water compared to 10% on the other side, water's going to be drawn to it. So do you see how water is drawn to the area of higher osmotic pressure? So in my mind, not in your book, but in my mind, I think of osmotic pressure as a pulling pressure for water. Okay? Higher the osmotic pressure, the more water stays there. Does that make sense? Okay, if we go back to your blood vessels. Okay. Let's say here is a blood capillary, which we'll look at in the next unit when we compare the different blood vessels. But for right now, just realize the blood capillaries are the thinnest walled blood vessels, and that's where substances move in and out of the bloodstream. It's through a capillary wall. All right, and blood is moving in this direction, like this. It moves in one direction. And let's say here's some body cells. Okay. All right, and they need some of the things dissolved in the blood. All right, because the blood plasma has albumins in it, because it's the most numerous substance in blood plasma, that helps to give the blood the most osmotic pressure. Okay, all right. There's also another pressure in the blood due to the presence of the water. The more water that's there, the higher the hydrostatic pressure is. If we go back to A and B, A has a higher hydrostatic pressure than B does, doesn't it? Yes or no? Yes, 90 compared to 80. Do you see how water moves away from the area of higher hydrostatic pressure? So I think of hydrostatic pressure as a pushing pressure for water, osmotic pressure as a pulling pressure. Okay, you have dissolved things in all your body fluids that give it osmotic pressure. All your body fluids also have a major water component that gives it hydrostatic pressure. So it's the combination of both those pressures in both places that determines where water's going to move in the body. Okay. Because of the elevated hydrostatic, you don't have to write this down, just watch. Because of the elevated hydrostatic pressure in your blood, that's the reason substances move out into your tissues so that those things can get to your tissues. But because of the osmotic pressure, everything doesn't move out. It loses some of it. So you got osmotic here and hydrostatic here. You got osmotic in the blood and hydrostatic in the blood. You got them both. So it's real complicated. You have to sum up the pressures on both sides. But just trust me, water moves out at this end of the capillary. And because these proteins are too big to cross, they stay in. So because they're here, do you see how the osmotic pressure will build up as it loses water? Okay, and that draws water back in, bringing with it things from your cells. Okay, so that's why you don't lose too much water at your blood. You don't bring all of it in, but you bring a bulk of it in, and it's because the blood has this osmotic pressure. Okay, if a person has a severe protein deficiency, let's say someone, bless you, someone lives in one of these countries where they don't get meat in their diet and they eat rice all the time. So they're getting calories, but rice is what we call, all the plant foods have incomplete proteins. They don't have all the amino acids that you need. Certain combinations of them do, like red beans and rice would have everything you need. But if you had just plain rice, you're not getting enough complete proteins in your diet. So your body is going to start breaking down its own proteins. And the ones it chooses to break down are these. You start breaking these down. Do you see how the blood loses osmotic pressure? So not enough will be drawn back in. And your tissues are going to swell up. That's called fluid edema. So that's why people who are starving, you see pictures of little children starving in Asia, some of these impoverished areas in Asia. Even though they're real thin, they look a little puffy. Their abdomen swells up. It's because their blood's not getting back its water component that it needs. And it's because their body is breaking down proteins in the blood, specifically, any proteins really, but as the albumins get broken down, the blood loses its osmotic pressure. It's a big deal. Osmosis is a really big deal in the body, and it's due to things not just proteins. Anything dissolved can give it some osmotic pressure. So we're going to see this in a couple of other units. This is your first real introduction to it. For this chapter, though, all you need to know for the test on albumins is that of all the proteins, they're the most abundant, and they give the blood its osmotic pressure. Don't worry about colloid osmotic pressure, but that osmotic pressure in your body fluids is referred to as colloid osmotic pressure. Okay? So does that make sense? Okay. What about all the other proteins? Globulins, there's different kinds of globulins. We can lump the alpha and the beta globulins together, and what they do, anything that is lipid soluble can't dissolve in the blood plasma by itself, like lipid soluble hormones. Remember that? And so they have to bind to proteins in your blood, and the combination is dissolvable. All right, and so that combination is called a lipoprotein, and alpha and beta globulins are involved in that. They transport any lipid-soluble substance, cholesterol, triglycerides, phospholipids, lipid-soluble hormones, lipid-soluble vitamins, all that kind of stuff is transported by alpha and beta globulins. And then a gamma globulin, that is a fancy name for an antibody. Okay, so in the next unit, when we study the lymphatic system, we'll be looking at your immune system. That immunity is part of the function of the lymphatic system. And we'll see that the chemicals called antibodies molecularly are gamma globulins. Okay? So if you went to the doctor, I know, let's say if somebody has hepatitis, their family members or people they come in close contact with, they may have to be given, may tell them, you need to get your family up here. They need a gamma globulin shot. That's an injection of antibodies, which is a little short-term immunity for that person. Okay. Um, okay, and then the third kind of plasma protein is called fibrinogen, and it's involved in blood clotting, which we'll look at in just a few minutes. Blood coagulation, that's another name for blood clotting. Okay. All right. You don't have to know any of the percentages exactly. You just need to know that of all the proteins, which one's the most abundant? Albumins. You don't have to know where they come from, but you need to know they give the blood its osmotic pressure. Okay? And then the globulins, the alpha and the beta, are involved in transporting fat-soluble substances. The gamma globulins, another name for antibodies, and then the fibrinogens involved in blood clotting. That's what you need to know about those. Okay? All right. So, what about some of the other things in your blood plasma? We have gases, the most important being oxygen, carbon dioxide. They can be dissolved in blood plasma. Lots of nutrients, individual amino acids can be dissolved, simple sugars, nucleotides. Remember, nucleotides are involved in the making of DNA and RNA. They can be dissolved. And then various lipids are in your blood plasma, but they're not by themselves. They're combined with those alpha and beta globulins to form these things called lipoproteins. And these lipids include fats, phospholipids, cholesterol, lots of different kinds of lipids. Okay. You ever heard, I know you've heard of this, like if somebody had a blood panel run, their lipid panel, and they're looking at the HDLs and the LDLs. Those are some examples of lipoproteins. High density lipoproteins, low density. Some of those have a higher cholesterol content than others do. Some have a higher triglyceride content. We'll see that in another chapter. We'll look at those. Okay, and then kind of a unique, kind of interesting substance that can also be found in your blood plasma besides the proteins are some things that we call non-protein nitrogenous substances. Proteins have nitrogen in them. You know, amino acids have an NH2 on one end. So amino acids are nitrogenous substances. Proteins are, but proteins are real abundant in the blood plasma, but there are other nitrogen-containing substances in blood plasma, and that's what these are. Like plain old amino acids, all right? But I'm going to circle these. Urea, uric acid, creatinine. All right, these are some non-protein nitrogenous substances that are byproducts of the breakdown of organic things in your cells. Okay? And they are waste products, meaning you've got to get rid of them. Okay? The biggest one in abundance is urea. Every time proteins are broken down, the little NH2 group is broken off of an amino acid, and a couple of those are combined together to form urea, and your kidneys get rid of it. That's where we get the name urine, because there's a lot of urea in it and uric acid. So I know I've gotten pretty wordy on this. You just need to list these non-protein nitrogenous substances. Why don't we just list the ones I've circled? The amino acids are not necessarily waste products, but of the others, urea, it comes from the breakdown of protein. Uric acid comes mostly in us from the breakdown of nucleic acid, and creatinine comes from the breakdown of creatine phosphate. Remember creatine phosphate in your muscles? It was kind of like ATP. As it's broken down, the creatine becomes creatinine, and it becomes a waste product. And these three, this one, and this one, are waste. So your body's got to get rid of these. Okay? And your kidneys are involved in that. Okay? And they help to determine your blood urea nitrogen. And I'm not putting the blood urea nitrogen on your test, but you hear about this in a medical setting quite a bit. If that amount elevates too much, that's an indication of renal kidney failure. Okay? It's a big deal if your kidneys are not removing this adequately. Um, that can be fatal if it's not treated. Okay, so some of you will be dealing with that in the medical world. Everybody will be if you're going to be a nurse. At some point, you'll encounter that test. Okay. All right, and then lots of electrolytes. Those electrolytes are just ions, right? They're just ions. You do not have to list these for me. Just know there are electrolytes and they're ions. But here you can see examples: sodium, potassium, calcium, magnesium. You know, if you have elevated amounts of these, your kidneys will remove them. But they need to be in your blood, available to your cells, because all of these electrolytes are used in various chemical processes in your cells. Okay. So really, you don't really need to know anything about this slide as far as question on the test, other than you have a lot of electrolytes dissolved. Okay. All right. So if we look at, we can go and analyze your notes and talk through your notes just by looking at this little flow chart. In a drop of blood, about 45% of it is your formed elements, and the bulk of that is your red blood cells called erythrocytes. You can talk about the production of them, the breakdown of them, all those details, and all the characteristics of erythrocytes. And you can look at all the different white blood cells, the basophils, the eosinophils, and so forth. Talk about those. The platelets. And then in the plasma, you have the biggest part is water, and then second biggest would be the proteins. And of the proteins, you have albumins. They're the most abundant. They give it osmotic pressure. So do you see how you can talk through all of this? And then various electrolytes are there. The waste products, a lot of these are those NPNs, the urea and so forth. All kinds of waste products. Gases, you can see, you have nitrogen, doesn't do a whole lot, anything really. It just kind of goes in and goes out. But you have oxygen, CO2, dissolved. And then we didn't really talk a whole lot about this. We looked a little bit at nutrients, but all kinds of things are just dissolved. Okay. All right. So that's the component of all the components of blood. And then the rest of this chapter, we're going to look at some of the processes that blood goes through. The first one is hemostasis. That hemo means blood, stasis means stop. So this is talking about stopping the bleeding. I don't know that stoppage is a word, but I like that word, the stoppage of bleeding. Okay. There's a lot of processes involved in that to prevent you from bleeding out. A huge one is blood clotting, which is this third one right here. But there are some other ones too. So we're going to look at these one at a time, and they can all be occurring as a cascade of events going on at the same time. These are especially effective in small blood vessels, like a small tear or a tiny blood vessel that is torn. Okay, the larger the blood vessel, the less effective these are going to be. Okay. All right, so the blood vessel spasm, sometimes called a vascular spasm. Vascular means blood vessels. And basically what happens, it involves these smooth muscles in the walls of your little blood vessels. And a smooth muscle is, just think about this, imagine your body is a smooth muscle, and if somebody took a knife and cut you, your first reaction is going to be to curl up, isn't it? Instead of to go out like this, just to curl up. All right, that's what a smooth muscle cell does when it's injured. It contracts. And a lot of these smooth muscle cells encircle a blood vessel wall. So when they contract, do you see how it constricts the blood vessel? Okay. And if it's a tiny blood vessel, that constriction may be enough to close it off. Okay. So that's a blood vessel spasm. Okay. Okay. Then, during that spasm, which can last just a few minutes, this second event called a platelet plug might form. And here's a platelet plug. Platelets anytime they encounter a rough surface, they're going to stick to it. And then they start sticking to each other. Okay? Now, the lining of all of your blood vessels, if you look right here, this lining is simple squamous epithelium, which is very smooth. But if there's a tear, some of the collagen in the wall, I can't really show it here, but the collagen will be exposed. And if the collagen sticks out there, then the platelets bind to it, and then they bind to themselves and bind to themselves. So do you see how a little platelet plug can form? That's not a blood clot. It's just an aggregation of a bunch of platelets, which are super tiny. So it's got to be a tiny tear in order for that to be completely effective. Okay? All right. And that can occur as the spasm is occurring with the smooth muscles. So they all can occur together. Okay. Then blood clotting can kick in, and this is by far the most effective method because it goes and goes and goes and goes and goes and can get humongous. Blood clotting, the fancy word for that is coagulation, is clotting, blood clotting. And it is a chemical pathway. Do you remember? A chemical pathway is one reaction followed by another, followed by another, followed by another. Like cellular respiration is glycolysis is a little pathway within the huge one of cell respiration. Okay. Blood clotting is a pathway too. And along that pathway, there are a variety of enzymes that are referred to as clotting factors. If you are genetically missing any of those, your blood's not going to clot as effectively. That's what happens if somebody has hemophilia. They're missing some of the clotting factors. Right. You also need, in order for blood clotting to occur, you need vitamin K because it acts as a cofactor for some of these enzymes. Okay. All right. I'll come back to these last two bullets in just a minute. Let's look ahead. Okay, don't get overwhelmed. I'm not going to ask for a whole lot of detail on this. Okay, but there are two different triggers for blood clotting. One is just when tissues get damaged, that triggers what we call the extrinsic clotting mechanism. These damaged tissues release an enzyme, one of these factors, that in turn sets off a series of reactions. But do you see how it ends up activating prothrombin? It's called prothrombin activator. That activates this little enzyme. Okay. The intrinsic pathway is when blood encounters a foreign surface. Air could be a foreign surface. It's not supposed to encounter air. All right, and so it starts, the blood itself goes through chemical events that go with little pathway, each time activating an enzyme along the way. But do you see how it ultimately ends up at the same point? And this same point right here is where we're going to start with you learning a little detail on this. Regardless of the trigger, you don't have to know the triggers. You won't see the words intrinsic or extrinsic on your test. But once blood starts to clot, it's a series of reactions occur to cause something called prothrombin activator to be produced. Prothrombin activator. Prothrombin activator is an enzyme that in turn converts prothrombin into thrombin. It converts prothrombin into thrombin. And then thrombin is another enzyme that, look at this, this is the main event for blood clotting. That's a big old asterisk. The main event. The presence of thrombin causes fibrinogen. Remember fibrinogen? Okay, it's one of the basic blood proteins. Fibrinogen normally is dissolved in the blood plasma, but in the presence of thrombin, it comes out of solution and forms fibrin strands. physical strands, and they form a mesh that traps anything solid coming along, especially red blood cells because they're so abundant. And so the combination of all the blood cells and the fibrin strands is what we call a blood clot. And as that forms, this is a positive feedback mechanism. So even more occurs, even more occurs, even more occurs. So a blood clot can become macroscopic, become very large, to stop the flow of blood in a blood vessel. Okay? All right. So you will not have to name any factors like factor 8, factor 5. Don't worry about those. But each of these factors is a type of protein, and if you're missing the gene to code for that, you have a disease called hemophilia. You may have heard of that, where the blood doesn't clot as efficiently. And that can be very, very serious. So those people are constantly having blood transfusions, and they're getting, some of these clotting factors you can obtain yourself, artificially. But so if I back up, the major event is the conversion of soluble fibrinogen into insoluble threads of fibrin. Okay? And that traps the cells to form the clot. So on the picture on the right, you can see scanning electron micrograph that's color enhanced. And so you see the yellow fibrin threads and you see all those trapped blood cells. Okay. Okay. Now, you have chemicals that you naturally produce that enhance the ability of the blood to clot. Those are called procoagulants. And then you have other chemicals that go against blood clotting, so it helps slow down the blood clotting process. Sometimes those are anticoagulants. A lot of times we call them blood thinners. Like heparin is a very powerful anticoagulant. Some people genetically don't produce a good balance of pro and anticoagulants, so their blood, they may produce too many too many procoagulants and not enough anti, so their blood may have a tendency to clot more, which can be very devastating. Or maybe it doesn't clot enough. So if there are tears, maybe the blood bleeds too much. Yes. But most of us, we have a good balance between those. Here's another picture that shows a real blood clot. Okay. So eventually, the blood clot is going to dissolve itself because you have a lot of anticoagulants come in and shrink it. Serum, blood clot releases serum. That's everything in blood plasma except the fibrinogen. So serum, you need to know this word, just like a word to define. Serum is blood plasma without fibrinogen. So see how the fibrinogen was taken up in a blood clot because it was converted to fibrin? And so the rest, what remains in the blood plasma is everything except that fibrinogen. So that's called blood serum. And in a lab setting, serum is used quite frequently as a dissolving medium for maybe some drugs. But it can stay on a shelf a long time. It won't clot. It won't form the fibrin strands. Whereas if it had fibrinogen in it, it would when it encountered the air. Okay. So sometimes you hear the terminology serum, and that's all it is. It's blood plasma without fibrinogen. Okay. All right. So don't worry about this part on your test. Don't worry about that. But you do have, after a clot is formed, there are events that occur after the clot to help get everything repaired. Okay, and that's what some of this is talking about. But I do want you to know what serum is. All right. Now, if a clot forms when it's not supposed to, it's good that we have blood clotting. All right, but sometimes blood will clot abnormally. And that abnormally formed clot, there's no tissue damage or anything. It's just the blood just clots. That's called a thrombus. Okay? And let's say a thrombus is in this blood vessel and there it's formed right there. If it stays there, everything's still okay because the blood can bypass that, right? But if it breaks off, it starts circulating in the blood, and one blood vessel branches and becomes smaller and smaller. And so, do you see how it can get lodged somewhere? Okay. All right. If a thrombus breaks loose, it's called an embolus. Okay, you've heard of that term. And that embolus then is a blood clot that's moving around in the bloodstream. If it gets lodged in a tissue, once it gets lodged, that results in an embolism. You may have heard of that, embolism. For example, a pulmonary embolism is a blood clot that has lodged. It's broken, a thrombus, it's broken off, and that embolus then has lodged in a pulmonary artery, which can shut down your breathing. If there is a coronary embolism, that's a blood clot that has lodged in a blood vessel supplying the heart, and that can result in a heart attack. If it's a cerebral embolism, that's a blood clot in a blood vessel in the brain that's lodged there, and it can stop the flow of blood to brain tissue, which can cause a stroke. Okay, so you hear this term sometimes. I've talked about heparin. Remember, that's an anticoagulant. Okay, and it's secreted. We've already talked about this by basophils, but back in AMP1, we saw it secreted by mast cells, which are kind of like basophils that get out into the tissues, and that helps prevent the clotting. So if somebody has suffered from an embolism, they're going to give them heparin or other anticoagulants to try to dissolve it. Okay. An embolism is a danger from most any kind of open surgery. Okay. Several years ago, there was a football player at Mississippi State, and I think he tore his ACL during the game, so he had to have knee surgery. But several days later, the knee surgery was fine, but several days later, he died of a pulmonary embolism. So during that knee surgery, the blood was exposed to air, so it would have a tendency to clot. All right. Have you ever known somebody who has had knee surgery? As they're recovering from it, they have to wear those real tight leggings or hose, those pressure socks. And what they're doing is keeping the blood flowing so it doesn't pool. When blood moves, it has less of a tendency to clot. If it sits still, that deep vein thrombosis, you've heard of the deep vein thrombosis? All right, anyway, if the blood clots then, which evidently it did with this student, either because it was exposed during the surgery or as he recovered, the blood stayed still too much in his legs, but a thrombus formed, broke loose, and made its way to the heart, and then from there to the lungs and lodged in one of the pulmonary arteries. Very, very serious. You hear sometimes about people having blood clots after they've been on a long plane flight. That's that what we call deep vein thrombosis. When your legs are real still, we're going to see in the next chapter why when you move around it gets your blood flowing. All right. When your legs are real still for a long period of time, blood pools there. And if it sits still, it's going to have more of a tendency to clot. It needs to be moving all the time. So that's why it's good if you are sitting down for a long time to get up and move around periodically. Okay, so here's some of those terms. All right. A blood clot that forms in a vital organ. An embolism is one where it's traveled and then lodged. Okay. Infarction, like a coronary infarction, that's a fancy name for a heart attack. That's just death of tissues when they don't get enough oxygen. Okay. Some people tend to form a thrombosis or a thrombus. You can interchange those. Thrombosis or thrombus, either way. Some people tend to form that simply because they got a lot of fatty buildup in the wall of their arteries. Because if there's fatty buildup, the artery wall is going to be rougher. If it's going to be rougher, it's going to have a tendency to clot. Okay? It's not smooth anymore. That condition is called atherosclerosis, which can be devastating. So your diet can cause you to have that. Okay. All right. Um, the last thing we're going to look at in this chapter is your blood types. But that involves chemicals in your blood called blood antigens and blood antibodies. Okay? And we've not used these terms much. We hadn't used antigens at all. But we will when we get to the lymphatic system and talk about immunity. All right, and so what I would like for you to do is just put your pencils down, and let me just kind of run through the difference in an antigen and an antibody. Okay. Before you are ever born, your little early immune system learns to recognize all of the molecules on your cells. You know how your cell membranes are a double layer phospholipids with proteins scattered throughout, carbohydrates on them, or some of those proteins and carbohydrates are recognizable by your immune system, and therefore it's not going to fight it. But later on, if you get some other chemicals in you, your immune system might recognize them as foreign, and so they start producing chemicals to fight them. And those chemicals that fight them are called antibodies. So what an antigen is any chemical that triggers antibody production by the immune system. Okay? We have self-antigens. Those are of you, and you don't produce antibodies against them. And then you have, or there are, non-self antigens that are coming in from somewhere else, like in a transplant. Okay, you know, when people reject an organ transplants because they're producing antibodies against them, because on those transplanted cells there are foreign or non-self antigens. Okay, your blood type. You might wonder, well, why are we talking about that in this chapter? This isn't the immune system chapter. All right, we're talking about this because those antigens, the self antigens that are on your red blood cells, determine what type of blood you have. Okay? All right, and so an immune response is just antibody release. Okay. All right. Now, I'll come back to the term agglutination. Don't worry about that. Let's look at our blood groups. You know, there are a lot of different blood groups. The ones that are worried about as far as transfusion is concerned are the ABO blood group and the rhesus factor. The rhesus factor determines if your blood's positive or negative, and the ABO is type A, type B, type AB, or type O. Okay, so let's look at those two blood groups, and then we'll talk a little bit about blood transfusions, when they work and when they don't. With the ABO blood group, there are two antigens involved, antigen A or antigen B. Okay? And this table is as if I typed it up, so you need to memorize this table. A person who has type A blood, that means on the surface of his red blood cells, there are antigen A proteins on the surface. And then his immune system produces an antibody, not that would fight A, because that would destroy his cells, but would fight the blood group antigen he does not have, which is the B one. So they produce an antibody called anti-B. Okay? A person who has type B blood has the B antigen, but he produces anti-A antibody. Does that make sense? A person with type AB blood, on each red blood cell, he has both an A and B antigens. And because he has both antigens, he doesn't produce either of the antibodies. Does that make sense? And then if you, about half of the population has type O. And that doesn't mean they have O antigens. That just means they don't have A and they don't have B. They have neither one of them on their red blood cells. But because they have neither antigen, they produce both antibodies. All right. So let's look at some pictures of this. Here's at the top left is type A. So do you see the orange antigens on the surface of the blood cells? See those? All right. And then the antibodies you see circulating in the blood plasma. So here's the antibodies. Okay. So there's an antibody. There's one. Each antibody is shaped like a Y. Don't worry that they're in a circle. But do you see how they have little green spots on them? These little green spots do not bind to that antigen. They're not a good puzzle fit. They're not a chemical fit, are they? But they're sitting there in case antigen B gets in this person's bloodstream, which is not supposed to be there. Okay? Here's type B blood. See, here's the B antigen, and here's anti-A antibodies. Okay? And then on the bottom left, you have type AB blood. See how they got both antigens on the surface of that red blood cell, but neither one of the antibodies? And then on the right, you see type O blood with neither antigen, but both kinds of antibodies. Okay, look at this. All right. If here's a type A blood, and do you see if they mix anti-A antibodies with it? Look at what happens. Look at this right here. Do you see how this antibody attaches to that A antigen? It's kind of hard to see. This screen is making it diffuse out. But then that one attaches there. But because this one's attached to that one, do you see how it's basically clumping together? Not clotting. This is not a blood clot because there's no fibrin strands in here. But the cells are clumping together. This is the real thing, where a bunch of blood cells have clumped together. That clumping is called agglutination. And that's what will occur if blood comes in contact with antibodies that are designed to fight that blood. Okay? And so they will agglutinate. Okay? And so in a blood transfusion, just think about it. If this is the donor blood, there's the donor blood. Okay? It has the A antigen. As it comes into the recipient, you don't want any anti-A antibodies in the recipient because it'll cause these cells to clump together before they have a chance to go anywhere, right? Okay. And so during a blood transfusion, it's very important that you make sure that the antibodies of the recipient will not fight the antigens of the donor. Okay? So, to prevent this agglutination from occurring. All right, and so I don't even want to put this up there. It's just telling you what you can get. Let me put a blank one. Okay, so here's our blood types. There's A, there's B, there's AB, and there's O. And here's the antigens. We have, what kind of antigen does A have? A. Type B blood has what antigens? B. Type AB blood has what antigens? A and B. Type O blood has what antigens? Neither. Okay? Neither. Okay? All right. Antibodies. What kind of antibodies are produced by type A blood? Nuh-uh. B is not an antibody. Anti-B is an antibody, okay? Anti-B antibodies. What kind of antibodies produced by B blood? Anti-A. If it produced anti-B, it'd fight itself, okay? What kind of antibodies are produced by AB? Neither. Okay? What kind of antibodies are produced by O? Anti-A and anti-B. Good. All right. In a blood transfusion, memorize this for a test. During a transfusion, what you have to worry the most about, you look at the antibodies of the recipient and you look at the antigens of the donor. Don't look the other way. Don't look at the antigens of the recipient and the antibodies of the donor. Don't do that. You will get the question wrong on the test. Okay? You don't want, so in other words, you don't want the incoming blood to agglutinate. Okay? Because it'll agglutinate right there as it comes in and it will be useless. But it basically works like a clot. I mean, it destroys red blood cells. Okay. All right. So let's say if a person has type A blood, let's look at what kind of blood types he could receive in a transfusion. The very best one would be A, one just like his. All right, so we're looking at the antibodies of the recipient. So the recipient is the person who's getting the blood. He has anti-B antibody. So he can successfully receive any blood that does not have what antigen on it? B. So he can obviously receive A. Can he receive type B? No. Can he receive type AB? No, because it has a B antigens in it. Can he receive type O? Yes, he can receive type O, because type O does not have B antigen on the surface of those cells. Those cells will not agglutinate. Okay, a person who has type B blood, what can he receive in a transfusion? He can receive B or O, because see, he has anti-A, so he cannot receive the A antigen. So he cannot receive type A, he cannot receive type AB. He can only receive B and O. What about a person with type AB blood? He doesn't have either one of the antibodies, therefore, no incoming blood is going to agglutinate, right? So that's why type AB is considered the universal recipient. It's the rarest of the 4 blood types, but it is the universal recipient, so that's pretty good. Okay. And a person who has type O, because he has both antibodies, can he receive A? No. Can he receive B? No. Can he receive AB? No. So the only one he can receive is O. Okay. He can only receive O, but he's the universal donor because he doesn't have any cells that would agglutinate. Okay. What was your question? O is not the rarest. It's actually the most common. It's the most common, but it only can receive O. But it's the most common, so that's good, right? Okay. So if I asked you a question on test and I gave you the type of blood of this group, type of blood of the recipient, and a type of blood of a donor, could you tell me if they could receive it or not? Okay. Explaining words like antigens and antibodies and agglutination. That will be. Yeah. For so make sure you understand that. All right. Now, if you think too hard, you'll start saying things like this. Don't write this down. Just let's say you're type A blood. So I can receive A and I can receive O. I get that. I get that, right? But why can I receive O? Because O has an antibody that would fight my cells. Ooh. What they do, I mean, it's not perfect, but you got to think about it. These antibodies are just coming in. These are the donor antibodies. They're just coming in, and so they're not all over that person's body yet. But what they do, the better. It's not as critical for the recipient blood to start agglutinating because there's so much other of it. Okay, it's just the donor blood you don't want to agglutinate. But what they do is pack it. They remove a lot of the blood plasma, so it's just packed cells, and the blood plasma is the part that has the antibodies in it. So that's limiting how many antibodies are coming in. Okay, if you don't have a perfect match between the blood types, they will pack the incoming blood. That means remove the blood plasma from it. So it's just the cells, because that's what you're needing is the cells. They could give you fluid in other areas, other ways. Okay? But I won't ask you about that on the test. On the test, you just worried that you don't want whose blood to agglutinate, donor or recipient. Oh, no. You don't want the donor blood to agglutinate. Therefore, you have to worry about the antibodies of the recipient and the antigens of the donor. You don't want the donor cells to agglutinate. Okay? All right. Y'all good? So here it tells you why you have a universal donor and a universal recipient. But so do you understand that now why blood banks are constantly wanting type O blood? Because it is a universal donor. Yeah. Okay. The other blood group that we worry about with transfusions is the rhesus factor, or Rh blood group. That determines whether your blood's positive or negative. And it is due to the presence or absence of a third type of blood antigen called antigen D, which is sometimes referred to as the Rh factor. Rh stands for the word rhesus, which is the genus for a type of monkey where this was first identified. You already knew that? Oh, oh, the monkey. It's a monkey. Yeah, yeah. That's where we're very, they're primates like us. We have a lot of common features, like the rhesus factor. All right. Um, if you have positive blood, regardless of if it's AB, or O, if it's positive, that means in addition to any other A and B antigens you might or might not have, you have antigen D. Okay? If you have negative blood, you don't have antigen D. Okay? So if you have A and B and that's it, you are AB negative. If you have A, B, and D, you're AB positive. If you have just D and nothing else, you are O positive, which is a whole lot of people are O positive. Okay? And then if you are negative, if you are Rh negative, you have the ability to produce anti-D or anti-Rh antibodies. But typically, those only form once the D antigen has been encountered. So let's say if you have negative blood, you don't automatically have anti-D or anti-Rh antibodies circulating in you. But if some positive cells get in you, you automatically are going to start producing the antibodies. And that's how most of the antibodies are. You don't make them until you encounter the antigen that they would fight. But so they also look at the positive and negative factors during a blood transfusion. But the question on your test will not involve that. It's just the ABO. Okay? Okay. Have you ever heard that sometimes there's a problem? There's a problem when a woman is pregnant and she has negative blood. Okay. Yeah. Okay, I'm going to put a new slide up. If this recording sounds funny, it's because my little, I don't know what this foamy thing is called on my mic, the filter is not on there. It fell off. So for everybody who's listening to this online, I'm sorry if it doesn't sound normal. You may need to turn the volume down or something. Anyway, I'm sorry. I'll fix it before the next recording. All right, here's a lady who is pregnant. She's very happy. And there she's pregnant. Okay. Oh, wow. And then there's the uterus. Okay, the baby's in there. All right, and let's say this lady has negative blood. She's Rh negative. So here's her blood cells. Okay, in here. And then the baby is in the middle circle. All right, let's say she has a baby who has negative blood, just like hers. All right. During pregnancy, there's a very special organ that develops called the placenta. And the placenta is loaded with baby blood vessels and mama blood vessels that are side by side. The blood of the mother does not get into the baby. and the blood of the baby does not get into the mother. However, substances dissolved in the blood plasma can cross from baby's blood to mother's blood, like nutrients, like oxygen, like CO2, like urea. All those things can cross, but the cells do not cross. Okay? Sometimes, though, when a baby is born during the birth process, tiny little tears occur in the placenta, and in that case, some blood cells may pass into the mother's bloodstream, or mother blood cells might pass into the baby's bloodstream. That doesn't always happen, but there's a chance for that to happen. Okay, so let's say this baby is born and the placenta does have little tears in it. So these babies' negative cells are going to get in the mother, but that's okay because hers is the same, right? It's no big deal. All right, so that baby's out of there. All right, so now she's pregnant again, and this is her second child. She's still happy. She wants to. And so, but this child's positive. Okay. Everything is just fine because this mother, even though she's negative, she's never been exposed to the positive cells. So she's not going to produce the antibodies to fight it. The anti-D, she won't produce it. All right, but so this baby's, everything's good. Now this baby is born, and let's say the little tears occur, and some of these baby cells get into the mother's bloodstream. So here's the baby cells in the mother's bloodstream. She automatically starts producing anti-D antibody. It's not going to harm that baby. He's out of there. The umbilical cord's been cut. Okay? But now she's pregnant again. Let's say. And she's okay with that one. All right, she's pregnant again. But because let's say, and this baby is negative. All right, remember I said antibodies can cross? Okay, things, if they're small enough, they can cross. So they get in here, but it's not going to hurt this baby because this baby has negative cells. And these are anti-D antibodies. This baby doesn't have D antigens, right? So this baby is born. Everything's fine. But now she's pregnant a fourth time. And she's not quite as happy. But I shouldn't do that. All babies are delightful, aren't they? Yes, but let's say this baby's positive. Now there can be a problem. Because these antibodies that the mother's produced are small. And they can get through into the baby's bloodstream while that baby is still developing and can cause clumping of those cells, drastic clumping. And that condition is a horrific condition called erythroblastosis fetalis. Means fetal, not fatal. Fetalis in the fetus. Erythroblastosis fetalis. And that, sometimes they refer to that as hemolytic disease of the newborn. And this baby can be born with a very compromised body because of those red blood cells. And so if a baby is alive when it's born that way, they will give that baby a full blood transfusion, which will get rid of all those circulating antibodies that came in from the mother. Sometimes the babies are stillborn, they don't make it. You don't see this as much anymore because today there is a shot that the mother can get a couple of times during the pregnancy. I think it's like, I don't know at what month during pregnancy. It's called a RhoGAM shot, and that prevents the formation of the antibodies. And they will just do that regardless of what the baby's blood type is. If the mother has negative blood, she will get the RhoGAM shot. And then she gets it again right after the baby's born to prevent any formation of the antibodies, just in case. So you don't see this so much anymore, but if it occurs, the mother is what? What type of blood? The mother is Rh negative, and then the baby is Rh positive. However, it's not the first Rh positive. It's the second or the third or the fourth. It's a non-first Rh positive baby. Okay? And this was a major reason for a lot of stillbirths before, say, the 1960s or so, before they started giving the RhoGAM shot. Okay? This is a major reason why it's important for every woman to seek medical attention, medical care during pregnancy, because some things can be prevented now. And this is a huge one. Huge. So you might wonder, well, if this is a problem with the negative and the positive, why is it not a problem with the ABO blood group? Because you can be type O and have any AB or O as your baby, and it's not a problem. And the reason is the anti-A and the anti-B antibodies are too big to cross, whereas the anti-D is small enough to cross. So that's very good, isn't it? We'd have a lot fewer people on this earth if it was an issue with the other blood types. But unless they had a shot to prevent, well, the antibodies are already formed though, so anyway, interesting. That's your book's view of what I just drew. So I kind of like mine. All right. When we get back from our break, we will start the next chapter.